So I'm Serge EVRARD, surgical oncologist from Bordeaux, France. I am a member of the ESSO, the European Society of Surgical Association, and the EURTC too. And we have a collaboration between the ESSO and EURTC, which is a circular platform. So my talk on parenchymal sparing surgery is to say that there is an evolution in the thinking of how we have to design the surgery of colorectal liver mets. In the past, there was a trend to propose extensive hepatectomies because we had the knowledge of the liver transplant, for example, and it was said that the biggest resection, the biggest amount of micrometastases we could remove. But it's not a good concept because you let some micrometastases in the liver remnant. So now more and more we are pushing the idea that the normal liver is not a target. We have to focus on the metastases and to protect the normal liver in order to make iterative surgery, to operate once, 2 times, 3 times, etc. And because clearly healthy parenchyma is not a target. So we have to demonstrate this. And we were among the first teams launching the concept of combining resection and intraoperative ablation, which is now accepted by most teams, but it was not the case 10 years ago. And so we proposed to make smallest resection focalized on the regions and intraoperative ablation, for example, when you have deep lesions deep in the parenchyma. In spite of removing a lot of liver, you just put the needle under ultrasound control and you destroy the lesions. And we have demonstrated on a prospective basis, RF 2003 study, that it was equivalent in terms of recurrences, local recurrences, and expectation of survival. So now we have to demonstrate that this approach is also compatible with chemotherapy, because one of the criticisms of extensive surgery was that it was not so compatible with chemotherapy. If you give more than 12 cycles of chemo and you did after a big extensive hepatectomy, you have a high rate of mortality. We have shown in this poster that you can do a lot of chemotherapy by the fact that when you remove some segments of the liver, mainly you remove a tumoral burden, not normal liver. So it's easy to understand that even if you make a major resection, you make it because you have a lot of metastases inside, and so it's more compatible with chemotherapy. So it's very interesting to see that you can do a lot of chemo before and after by the fact that you respect the liver, the normal liver. So it's a very interesting concept and completely integrating the notion of a multidisciplinary approach. The surgeon is important, but chemotherapy is also very important. You can do also ablations, etc., etc. So that's, I think, the new concept to deal in a modern way with colorectal liver mets. We have not so much impact of chemotherapy if we protect the normal liver from the resection. But of course, if you remove a lot of normal liver, you will have some problem because oxaliplatin is inducing syndrome of vascular lesions, and irinotecan is leading to steatohepatitis, etc. So if you give a lot of number of cycles, which sometimes is necessary, of course you can have some cumulative toxicity. But most of the time, in a routine way, the PSS, the parenchymal sparing approach, is compatible with an administration of chemo, both on the neoadjuvant setting and in the adjuvant setting. So we got a multidisciplinary staff discussion this morning with Gunnar Folprecht, with some other friend of mine about this discussion. The problem is, can we push the limits of the surgery, or should we say, okay, now we have to stop to make some barriers? So clearly, for liver only metastases, when the patient has only metastases in the liver and nothing else, I would say we have to push the limit because we have no demonstration that surgery is always doing better than chemo only. But for patients having liver and extrahepatic localization, like lung, peritoneum, etc., more and more you have medical oncologists saying it is not demonstrated that you are giving some additional chance to the patient. So Gunnar Folprecht is wanting to have a randomized study in this topic. So I clearly understand that the progress of chemotherapy is now at 25, 30 months. So mechanically, the progress of medicine will join, the result of surgery. So there will be a limit to surgical indications. But once again, for liver-only disease, I think there is a big place for surgery. As surgery is getting more and more safer, there are some indications for other non-colorectal cancers. First was neuroendocrine tumors, but the problem is that with the progress of MRI, we see that in the past we were used to say that when you see 5 neuroendocrine metastases, when you operate you have 10 or 20, because we have a lot of very small metastases. And now with the progress of MRI, especially diffusion-weighted MRI, we see more and more before operating, and so we have less indications because we know that most of the time we are in a palliative setting. But in the same time, for gastric cancer, for example, for some most indication of pancreatic cancer, sometimes a patient has a specific evolution. 3 years after the start of the treatment is always alive, and you have 1 or 2 mets not so growing. So you have to discuss in the MDT indications, and I know that in Japan they discuss more and more indication for gastric carcinoma, for example. And there is a project both in Japan and at the ERTC to have some prospective database to record this case, because they are not so frequent, so you cannot say we will randomize because you have not enough patients having this type of evolution. So the good response will probably prospective databases to see what we really offer to the patient in terms of quality of life and expectation of life too.